Hi, my name is Jana Leto, and I'm a Policy and Regulatory Affairs Manager with the California Telehealth Resource Center. I'm excited to kick us off with a three-part series on the digital health updates outlined in the recently released calendar year 2026 Medicare Physician Fee Schedule Final Rule. The updates we discussed in today's Spark session will be related to remote physiological management, RPM, and remote therapeutic management, RTM. Before we get started, we have a disclaimer. CTRC does not provide legal advice. All materials are strictly for information and educational purposes only. We strongly encourage you to reach out to your own billing and compliance teams to assess how the updates covered in this session may impact your organization. Before diving in this Spark session, I wanted to level set how we're going to walk through all the digital health updates in the final rule. There are three questions we need to cover up front before we even talk about coverage, coding, or reimbursement. So first is, what modality are we talking about? So this session is going to be focused on RPM and RTM. The provider type is we're going to be focusing on physician fee schedule, paid providers, federally qualified health centers, and rural health clinics. FQHCs and RHCs are paid under their own unique billing pathways, the FQHC PPS and the RHC rate. And who's the payer? It's going to be Medicare. And I'll keep reinforcing that because RPM and RTM can vary under other payment program types. So with those basics anchored, we'll walk through what CMS finalized for 2026 on coverage, coding, and reimbursement. This framing helps us keep RPM and RTM in the right regulatory lane. As I mentioned, this is the first in the three-part Spark series going over the digital health updates in the 2026 PFS final rule. The final rule was issued on October 31st, so it's Halloween surprise, and will become effective on January 1, 2026. We'll be discussing RPM and RTM today, but in other sessions, we'll be discussing Medicare telehealth and AI. So please keep an eye out for those and join us. So we were diving in, want to clarify that CMS does not consider RPM, RTM, and digital mental health treatment as Medicare telehealth services. These services are inherently non-face-to-face and therefore do not meet the statutory definition of telehealth services under Section 1834M of the Social Security Act. So they fall outside that telehealth regulatory framework and they don't require telehealth modifiers or geographic restrictions or originating site rules. So let's get in. Before moving into the changes, let's define RPM and RTM. So RPM involves the collection and monitoring of physiological data. So for example, your heart rate, blood pressure, glucose levels, or weight. On the other hand, RTM collects non-physiological data for health conditions. So that might be your musculoskeletal system status, your respiratory system status, adherence to medication, or patient response to therapy. So here we have the existing Medicare remote management code set before we dive into those 2026 changes. So you'll see RPM on the left and RTM on the right. And you can see that both of these code sets have an initial and set of patient education code in that first row right there. There's also a professional service code for the first 20 minutes. And then there's also an additional 20-minute code if you go beyond that first 20 minutes. You can see there is a difference in terms of device supply codes. So RPM only has one device supply code, and that's 99454, whereas RTM has three separate device supply codes, and that's for three different therapies. So you have one for respiratory, one for musculoskeletal, and one for cognitive behavioral. And please note that for cognitive behavioral, CMS has made that contractor price. So the Medicare administrative contractors, Max, are the ones that value that code. So what's changed for Medicare remote management? Across both sets of services here, you'll see that there are new 2 to 15-day device codes and new 10-minute time codes, which allows provider more flexibility for shorter episodes of care. There's also clearer rules around what counts as interactive communication. So for the treatment management codes, so those are the timed ones, such as the new 10-minute ones or the 20-minute ones that existed previously. CMS is requiring that there be a live interactive communication with the patient or caregiver. And it highlights 2 points from the CPT coding panel that this communication has to be live and two-way, like a phone or video call, and the live interaction only needs to make up a part of that time bill. So the full 10 minutes or the full 20 minutes doesn't have to be this live interactive communication. The rest of the time can be normal clinic work. We think of like reviewing data, adjusting a care plan, documentation, or coordinating care. CMS said that there's not added new restrictions and it will accept it as long as it meets the CPT definition of live and interactive. So CMS doesn't specify which technology can be used. CMS is also starting to use hospital outpatient cost data. This is called OPPS, geometric mean cost, to more accurately price device-related services. CMS is trying to keep RPM and RTM value consistently since the work for these services are often similar. So let's go through these changes. So RPM, there are two new codes. So you have 99445, which lets providers bill for shorter monitoring periods. So just 2 to 15 days of data in a month instead of the existing 16 to 30 days in a 30-day period. Then we have 99470, which lets providers bill for a shorter amount of time spent managing a patient. So 10 minutes instead of the usual 20 minutes. CMS also simplified coding rules, making it very straightforward. So you can only bill one device code per month. So you're only billing either the 2 to 15 day supply code 99445 or the 16 to 30 day supply code of 99454. You can't bill for both. For the monthly management time, you can only choose one starting point. So you're either starting with 10 minutes, 99470, or 20 minutes, so 99457. If you go past 20 minutes, you can add the extra time code of 99458. In terms of valuation, things get a little technical here, so let's break it down simply. So CMS assigns a value to each code based on the amount of time and effort involved. These values are expressed in work relative units, so shortened as WRVUs, and think of WRVUs as the weight CMS assigns to how much clinician work is involved. So for example, 99470, the new 10-minute code is valued at about half the 20-minute code of 99457 because it represents half the time. So CMS set it at 0.31 work relative value units, WRVUs, instead of 0.61. CMS decided to keep the current valuations for the 20-minute codes, so that first 20 minutes of 99457 and the additional 20-minute code of 99458, because the new survey data they got wasn't strong enough to justify changing them. So these codes are priced. How are they priced? The new device code 99445 and the existing device code of 99454 don't include clinician time. They're practice expense only. These cover the cost of the device and the data platform. So instead of relying on vendor quotes, which can vary widely, CMS is using that hospital outpatient cost data that I mentioned earlier, called the OPPS geometric mean cost, giving CMS a more reliable estimate of the real cost of the technology. CMS decided to give 99445 and 99454, that's our supply codes, the same payment amount because the device is usually provided for the full 30 days, even if the patient is only giving data for 2 to 15 of those days. So next up, we have RTM. There are new codes for this as well. 98979, which is the new 10-minute time code, similar to RPM's 99470. And then 98984 through 98986 are the new 2 to 15-day device codes for the different therapy types. So for 98984, that's respiratory, 98985 is musculoskeletal, and 98986 is cognitive behavioral. So the coding rules are very much like RPM. You can only pick one device code, so the 2 to 15 day or the 16 to 30 day for the therapy that you're billing for. And then you can only pick either the 10-minute code 98979 or the 20-minute code 98980. And if you go beyond 20 minutes, you can do that extra time code of 98981. CMS has also labeled several RTM codes as sometimes therapy. So that just means if a physical therapist or occupational therapist delivers a service as part of a therapy plan, then they're going to need to apply therapy rules. So that means, for example, there's going to be therapy modifiers needed. So you can see that in the orange text box here. You're going to need to add that CQ or CO modifier. If a doctor or nurse practitioner delivers RTM outside of a therapy plan, then you bill it like a regular RTM service with no therapy modifiers. In terms of valuation, CMS kept it similar to RPM to keep things consistent. So here's what they finalized. That 10-minute code, the new one, 98979, is valued at half of the 20-minute code, 98980. So that's set at 0.31 work relative value units, or WRVUs. The existing 20-minute codes, 98980 and 98981, stay the same. Like RPM, RTM has practice expense-only device codes, so they use the same approach. So 98985 and 98977 are priced using hospital outpatient cost data, so that's the OPPS GMC data. Then 98984 and 98976, that's for respiratory. That's going to be crosswalked to the 99454 RPM code. So that means the CMS is going to pay them the same amount as the closest comparable code. That's what crosswalking means. Then you have 98986 and 98978. So that's for cognitive behavioral. That's going to stay contracted price because cognitive behavioral therapy related devices still vary a lot, and CMS does not yet have reliable cost data. CMS also said that it's placing RTM on the new technology list. So that means it's going to revisit and reevaluate these codes after 3 years of claims. So we're going to move on now to the changes related to digital mental health treatment. But before we dive in, just a little bit of background. So these were finalized in last year's physician fee schedule, and it allows Medicare payments to billing practitioners for digital mental health treatment devices furnished incident to professional behavioral health services used in conjunction with ongoing behavioral treatment. So these devices, DMHT devices, refer to software devices cleared, approved, or granted de novo authorization by the FDA that are intended to treat a mental health condition by generating and delivering a mental health treatment intervention with a demonstrable positive therapeutic impact when used under a behavioral health treatment plan of care. So you can see the types of devices that these DMHT device codes can be used for, and that's on the right side here in that smaller orange text. So when these came out, we took a look at these to see how they compare to RTM codes. So CMS had finalized 3 HCPCS G codes for DMHT devices, and you can see that on the right-hand table here, G0552, which is an initial setup and patient education use code, as well as a supply of device codes. So unlike our RTM codes, CMS has opted to bundle that codes, whereas in RTM, there's 2 separate codes for those. Then we have G0553 and G0554, and these are professional services code. And for payment for these, CMS has actually crosswalked these with the RTM codes for payment. So let's get into the changes. CMS didn't actually create new codes. Instead, it expanded the eligible FDA classification. So now digital therapy devices for ADHD can be billed under these DMHT devices. CMS also chose not to expand or create new codes for devices under FDA categories for GI, fibromyalgia, or sleep disturbance. Likewise, for non-FDA cleared digital tools or wellness apps, and also add-on codes for autism spectrum disorder eye tracking technologies. Instead, CMS said it will continue to explore future expansion and is taking an incremental approach. The agency wants stronger utilization data and outcome evidence before expanding coverage to non-FDA cleared tools or new device categories. Agency said it's also going to continue to work with MACs to improve pricing consistency and clarify billing guidance. So for now, it's maintaining contractor pricing until sufficient data is available for national rates. Then we have our changes for advanced primary care management services. So these services, similar to DMHT, the codes for these were finalized in last year's rule. APCM services combine elements of several existing care management and communication technology-based services you may have already been billing for your patients. So you can see a listing in that blue text box. These elements of advanced primary care might include codes for principal care management, chronic care management, or transitional care management, and communication technology-based services, also known as CTRC, might involve remote evaluation of patient video codes, virtual check-in codes, and online digital E&M codes. So for 2026, CMS is building on the PPM model by finalizing 3 new add-on codes, G0568, G0569, and G0570 that integrate collaborative care and general behavioral health integration directly into the APCM. And this is without the burden of minute-by-minute documentation. These new codes mirror the existing COCM and BHI CPT codes, 99492, and 99493, and 99494, but they removed the time requirements entirely when delivered within a PCM. They are finalizing evaluation using a direct crosswalk to these codes. Again, 99492 and 99493 and 99484. You can see those there. That means that the new G codes carry the same work RVUs and practice expense inputs, but with simplified documentation expectation. The CMS also finalized that FQHCs and RHCs can build those new add-on behavioral integration codes within the APCM services. They are also unbundling G0512, which has historically been the bundled psychiatric collaborative care model code for FQHCs and RHCs. So, starting January 1, 2026, FQHCs and RHCs have to build the individual collaborative care model CBT codes that you can see here in this table instead of billing G0512, since that will no longer be payable. Payment for each component code will be based on the national non-facility PFS rate, and these services will continue to be paid in addition to an otherwise billable visit outside of the FQHC PPF and RHC AIR encounter rate. CMS plans to issue sub-regulatory guidance and other educational resources to help RHCs and FQHCs with this transition. Similarly, for FQHCs and RHCs as well, CMS finalized another unbundling of a code. So it's unbundling G0071, requiring FQHCs and RHCs to report the individual codes that make up this bundled code. Historically, G0071 combines several communication technology-based services and remote evaluation services into a single virtual communication payment. So starting January 1, 2026, FQHCs and RHCs will now have to report the individual codes that you see there, G2010, G2250, and 98016. CMS said it's also going to be issuing sub-regulatory guidance to help RHCs and FQHCs navigate this transition. So that brings us to the close of our remote physiological management and remote therapeutic management digital health updates in the calendar year 2026 Medicare Physician Fee Schedule final rule. We will have 2 more sessions that will go over the changes related to Medicare telehealth and artificial intelligence. We hope you will join us for those. If you have any questions, comments, and feedback on today's session, please use this QR code. The QR code also includes a link that will take you to our contact form if you have any specific questions about the material you learned today and would like to ask us more nitty-gritty questions. Please remember that we will have 2 more sessions in this Spark series, so we hope to see you then.